I should also say that Dr. Pidcock is a member of the Transverse Myelitis Association Medical Advisory Board. And another member of our Medical Advisory Board is Dr. Barnes. And we've been talking today a lot about some of the challenges that physicians face in making these diagnoses. And Dr. Barnes is going to talk about a few very specific challenges in differentiating between some of these neuroimmunologic disorders in children. Dr. Barnes?
All right, so just to let you guys know, I'm a pediatric neurologist by training, and I'm also the father of a special needs child, so I have a real heart for pediatric TM simply because I live as a special needs parent every day. So I was given the job today of telling you guys about how we as pediatric physicians try to really distinguish among transverse myelitis from acute disseminated cephalomyelitis, or ADEM, and this syndrome that's called CIDP. You can think of CIDP as chronic Guillain-Barré syndrome, or a chronic inflammation of the peripheral nerves. So you have a relapsing course of inflammation of peripheral nerves. But the acronym here is called CIDP. Let's see. How do we push that up? How do we push that? Okay, so an overview of the talk. We're first going to talk about what is pediatric TM and what can be the first presentation of that. And then we're going to differentiate the clinical characteristics of pediatric ADEM and how do we distinguish pediatric TM from ADEM. Too many EMs there. Anyways, secondly, the last part of the talk, we'll talk about the clinical characteristics of pediatric CIDP and how you distinguish TM from CIDP. There was a recent article that was published in the Journal of Pediatrics by Michaeloff et al. That really looked at, for the first time, how frequent is CNS demyelination in children. And this included children under 16 years of age that were admitted to 12 pediatric neurology centers in France from the years of 85 to 91. And their exclusion criteria for the study was a preceding neurological abnormality, metabolic cause, some sort of infectious cause, or systemic immunologic disorder. So that certainly does exclude some of the causes of so-called pediatric TM. But nonetheless, just looking at this, there was the follow-up period was about 3 years, plus minus 3 years, with 20% of the patients actually followed greater than 5 years, not less than 5 years. So there was over 300 patients, most of which were Caucasian. The onset of their first attack of demyelination was approximately about 10 years of age, but it really differed depending upon what the eventual diagnosis was. For multiple sclerosis in pediatrics, the age is usually older. It's about, in this study, it was about 12 years of age. Versus with ADEM, ADEM tends to be a diagnosis of children who are younger, with an average of about 7 years of age. Of these single focal episodes, most of these ended up being TM, and the average here was about 9 years of age. Now, what was, as has been reinforced before with talking about either TM or ADM or multiple sclerosis, there are certain characteristics that even at presentation in the pediatric population tended to distinguish the final diagnosis. Infection during the preceding month tend to be more common in the ADM or the focal episode population than it did in the multiple sclerosis population. As I said, those with single focal episodes tend to be mostly comprised of eventually of transverse myelitis. Optic neuritis in general is much more common even in pediatric multiple sclerosis than it is in ADM. And involvement of the lower part of the brainstem, tends to be much more common in ADM versus multiple sclerosis. And a really important sign that I wanted to emphasize is severe mental status changes, or people and kids who are not talking in their right mind, are sleepy, etc., are much more common in this acute disseminated encephalomyelitis than in multiple sclerosis. The initial MRI findings actually were actually quite predictive, and the group with a final diagnosis of acute disseminated encephalomyelitis, the MRIs that were suggestive of ADM were present in 100% of the cases, and 15% of the cases were suggestive of multiple sclerosis. And the converse, in the group that had the final diagnosis of multiple sclerosis, roughly about 60% were suggestive of multiple sclerosis, and none were really suggestive of ADM. So the MRI findings can be incredibly helpful in this time. The distribution of the MRI lesions tended to be, you tend to see involvement of the deep gray matter much more in ADM. You tend to see more involvement of the optic nerves or the spinal cord lesion in multiple sclerosis. And gadolinium enhancement tends to be much more common among people and kids who had multiple sclerosis versus ADEM. Now, the findings for the spinal fluid examination, you tended to have greater than 10 WBCs in the CSF, more so in the less so in the multiple sclerosis population, and much more so in the ADM. And protein tended to be also higher in the ADM group. And a very important indicator, this indicator of synthesis of the antibodies within the central nervous system, the so-called oligoclonal bands, tend to be much more common in children who had the final diagnosis of multiple sclerosis. So the bottom line from that study is this slide, okay? So the factors that were predictive of a second attack tend to be the age of onset, with those of older onset likely to have a second attack of demyelination. A presence of either transverse myelitis or optic nerve lesions tended to be more predictive of a second demyelination attack. And an MRI, obviously suggestive of multiple sclerosis, was predictive of a second attack. Something that suggested that it would only be a monophasic illness was an MRI at onset suggestive of ADEM. So Frank had mentioned already the study in the Journal of Child Neurology, 2003, of Dr. Dufresne, in which he looked at 24 patients who had who had pediatric transverse myelitis. And he defined that as an acute bilateral onset of spinal cord dysfunction, and again excluded a number of different things that we've talked about before. The incidence that he quotes in the article is anywhere from 1 to 100,000 to 1 to a million, depending upon the studies you look at. Again, similar to what Frank found in the Johns Hopkins study, the average age of onset was about 8 years of age, and the male to female ratio was about 1 to 1. 60% of the kids had some sort of infection, usually a URI. And actually, in their study, about 50% of the cases actually ended up in the winter season versus in the summer season. They also noted that fever was a prevalent symptom in about 60% of the patient. In this initial phase, the so-called first 5 days that Frank talked about, the severe symmetric pain was present in over about 90% of the patients in one or more of the spinal segments themselves. And that tends to be true with ADEM, pediatric transverse myelitis. In those diseases, especially in the kids who are much younger, they tend to have much more in the way of severe pain. Sometimes the pain is so severe and so irritable that you think that they may actually have some sort of change in their mental status or changes in their level of consciousness. This is a rather busy slide, and the main thing I wanted to point out in this slide was that most of the kids had severe back pain, and most commonly it was found in the neck region, so suggestive of some sort of so-called inflammation of the neck or meningismus. 23 of the 24 patients actually presented with a symmetric flaccid paralysis of the lower extremities with a sphincter dysfunction. And unlike in some of the adult patients, actually one or more detent reflexes, or the reflex that when we tap on your knee, your knee jerks, the detent reflexes tended to be abolished in about 83% of the patients. So a fair number of pediatric patients actually look like they have spinal shock, and it becomes difficult for us to actually distinguish whether they have some sort of compressive lesion versus transverse myelitis. And that's why we in pediatric population, we tend to send our kids almost immediately to the MRI scanner from the emergency room to rule that out. Abnormalities in sensation were very common, and a lot of times in kids it tends to be asymmetric. Mostly the levels are in the thoracic region, and sphincter dysfunction is very prevalent, and it usually requires a catheterization for a mean of about 2 weeks or so. In his particular study that he published, the mean duration of follow-up was 7 years. All of the kids were treated with IV solumedrol. Their mean time to independent walking was roughly about 2 months. Frank went over before some definitions of what constitutes a normal recovery, a mild motor recovery, or moderate or severe motor recovery. And the way Dufresne defined that was very similar to what Frank published before, or defined in the last talk. Those that only had some mild spasticity but had good ambulation, or those that had normal walking, constituted roughly about 60%. But there was this 37 to 40% that really had moderate to severe sequelae. So numbers a little different from what Frank had, but pretty consistent with what's been in the literature before. There were a couple of factors that were predictive of unfavorable outcomes. One was an onset of a complete paraplegia, and then the time, especially with the time of the maximum deficit, to less than 24 hours. And that tends to be my experience too, especially in younger children. The favorable outcome predictors included a plateau phase that was less than 8 days, or kids who started walking before 30 days after the onset of their symptoms. In his particular study, there was no recurrence of their TM or other neurologic deficits in the 7 years of follow-up. As I said, I've seen it, but I will point out that the average age was about 8 years here, so there was a number of younger patients in this population, so it could be that the teenagers just weren't picked up in this study. The most common abnormalities that we saw in the spinal fluid were elevated white blood cells with a mean of about 210 cells. Protein was actually only slightly elevated up to about 120 in only about 3 of the 24 patients. And about 5 of the 24 patients had some sort of recent evidence of a viral infection. But most importantly, none had this evidence of this synthesis of this of antibodies within the central nervous system, the so-called oligoclonal bands. And the MRIs we've talked about before, they tend to be swelling and increased T2 signal within the thoracic regions, but some in the cervical regions and the lumbar regions. And the swelling tends to be located within the white matter of the central part of the spinal cord itself. Now let's contrast that with this disease called acute disseminated encephalomyelitis, or ADEM. This is an inflammatory demyelinating disease that occurs usually after a viral infection, sometimes after a vaccine. As Doug alluded to previously, it's typically monophasic in about 90% of the patients, but there is a clear set of patients, and somewhere between, in one study it was 10%, it can vary between 2 and 10%, where their kids will have multiple episodes. There is a clear infectious event and or a vaccination, usually 1 to 4 weeks before the onset of neurosymptoms, in about 3/4 of the patients. And the typical time between, say having a fever and then the onset of the neurological symptoms tends to be about 2 weeks. The age of onset tends to be younger. Those with, as I said, those who are 3 years and less, they tend to be extremely irritable and a tremendous amount of pain, and it really looks like they have meningitis rather than this demyelinating episode. Many of these numbers come from this new study that was published in the Green Journal of Neurology in 2002 from Argentina. It was 84 consecutive patients. 35% of the kids have some sort of non-specific upper respiratory infection, and 26% of them had no prodrome whatsoever. Only about 12% of them ended up having some sort of vaccination history. The main points about this particular slide is that ADEM, unlike pediatric transverse myelitis, has these changes in the sensorium in a vast majority of the patients, and oftentimes there's a hemiparesis instead of a paraplegia. Oftentimes as well, you have the onset of this unsteadiness in the children, so-called cerebellar ataxia. And as I said, in children, neck pain is very, very prominent. The so-called meningeal involvement or neck pain, because there's irritation of the covering of the brain, so-called meninges, is about 40–50%. And oftentimes they can have some headache and or vomiting from increased intracranial pressure. Things like optic neuritis or visual loss are much less common in ADEM versus in multiple sclerosis, as I mentioned before. The radiological features, I think we've gone over this pretty much in gory detail, so I won't bore you guys with a recapitulation of this. Just to remind you that usually what is seen is that you have these increased T2 signals that are usually less than 5 millimeters, both in the gray matter, or the areas of the nerve cells, as well as in the white matter itself. And they tend to be scattered and asymmetric all over the brain. There are some times where they can involve the deep gray matter as well, and that can be certainly can be a diagnostic tip-off. In ADEM, about 30% of the patients will have cells that will be less than 180 cells in the CSF. The protein is in about 40% of the kids can be elevated. But most importantly, that oligoclonal bands, the synthesis of the antibodies within the central nervous system, is negative in about 96% of the patients. ADEM is one pediatric demyelinating disease that certainly does respond to solumedrol, and most pediatricians who treat ADEM really feel very, very strongly about that. Now, do we have any head-to-head clinical trial evidence to back that up? No, we don't. But most of us feel pretty strongly about that. Unlike in pediatric TM, where we don't know we're not as strong on the using steroids, although we all do. But certainly, with the use of 20 mg per kilo of solumedrol for about 5 days, kids tend to get a lot better, a lot faster. And certainly it's nearly all of us will use some sort of regimen like that IV initially in treating the child. Many of these children end up in the ICUs, usually for changes in the levels of consciousness, and or they actually end up having some sort of ventilation. Now this is the outcome data, and just to remind us that the solumedrol and or the dexamethasone, another steroid, was tapered over about 4 to 6 weeks, and their mean follow-up was actually about 6.6 years. And what they did was they ranked the outcomes by the MRI scans. Now, just to remind everybody, the most common scan, those that have these small scattered lesions that are asymmetric in both the gray and the white matter, that was the group A. Those patients, 96% of those patients ended up having a normal or nearly normal outcome. And that tends to be the norm in most of the kids that we see with ADM. There are those that have either involvement of the deep gray matter and or other places, such as when you have a hemorrhage within the demyelinating lesion, and the outcome is less than that. But these kids in groups B, C, and D tend to be much less in terms of the types of the patients that we see. Normally, most of the patients that we see are in this group A that have a fairly good outcome. Residual neurological deficits that you can see, mild paraparesis certainly is one of those, and you can see a transverse myelitis in association with an ADM-like picture, and that can occur in about 4% of the patients. Oftentimes, the major thing that I will see in follow-up will be these usually a mild hemiparesis and or a symptomatic seizure disorder of some sort. He quotes in his article that this so-called mental handicap was present in only about 4% of the patients, but I find this to be probably the most troublesome outcome out of all of them. These kids tend to have problems in school, problems with attention and problems with reading and problems with memory. Those can get better with time, but it takes a couple of years before those do get better. Now, as I mentioned, there is this so-called multiphasic ADM. Usually it's biphasic, meaning that there are maybe 1 or 2 relapses. The age of onset of those kids actually tends to be a little younger than the regular series. The regular series was about 5 years of age, and these guys are about 4.6 or so. The mean intervals between the relapses can actually be fairly long, can be about 3 years. But in the mean period of follow-up of about 8 years, no patients who had this biphasic or multiphasic ADM ever developed the synthesis of these antibodies within the central nervous system, which is certainly is a marker of continuing multiple sclerosis. So. Now, how do we distinguish that from this disease called Pediatric Chronic Inflammatory Demyelinating Disease, so-called CIDP? This is a relatively rare form of chronic inflammation of the peripheral nerves. The incidence, which is quoted at 1 in 100,000, is probably rarer than that. It's defined as a subacute onset of progressive or proximal and distal weakness at least over 2 months. So unlike ADM or pediatric TM, this weakness really occurs over a number of months rather than a number of days. Ann Connolly, who is a neuromuscular pediatric neurologist at St. Louis Children's Hospital, really defines this disease as a progressive or relapsing motor or sensory dysfunction of more than one limb and hyporeflexia or areflexia in all 4 limbs. So again, this could initially fool somebody as, well, maybe this is a kid who's in spinal shock, but the history, of course, is much different. You have it over 2 months. And the average age of onset, unlike ADM and pediatric TM, again, is older. It's about 11 years of age. This group overall tends to have two groups. There is a small percentage of the patients who tend to have a monophasic illness that presents over to 1 to 3 months, and it's often improved by treatment that is also used for pediatric TM and ADM. But there's this usual group, that about 83% of them, that have this progressive loss of ambulation over 3 months, and they tend to have this relapsing course, and the usual is about 4 to 5 episodes. You see both fatigue as well as sensory symptoms, including this pins and needles feeling. And large fiber sensory loss tends to be much more common than this small fiber sensory loss. The percent of need for ventilation in any one episode is about 10%, so there is some morbidity to each of these episodes. The electrophysiology can be helpful, and I'm not really going to go over these as much, but just to let you know that the EMG nerve conduction velocities can be helpful in distinguishing these. So how do you distinguish CIDP from, say, transverse myelitis? With transverse myelitis, it has a much more acute onset. There also are these chronic inflammations that are actually congenital, so-called the peripheral nerves, so-called hereditary motor sensory neuropathies. The motor weakness in those children tend to be much more in the much more distal, or much more in the feet and in the calf area, and the sensory loss is usually much more severe in CIDP. And usually, if you look at mom or dad, they usually have it as well. It's a dominant inheritance of these neuropathies, meaning that the gene tends to be passed down to every generation, and at least in 50% of the children. And there, again, these EMG nerve conduction velocities can be helpful in terms of distinguishing them from CIDP. Another mimicker of CIDP can be the so-called acquired myopathies, so-called dermatomyositis, which may mimic CIDP when the rash is not present. Normally, the dermato part of this, the rash, usually distinguishes it from CIDP. But in acquired myopathies, you usually have evidence of muscle enzyme elevations, which is not seen when you have inflammation of the peripheral nerves. And the last thing that can mimic CIDP can be these degenerative diseases, the so-called autosomal recessive neuropathies. These diseases can have involvement of the peripheral nervous system first, and then following that, the children develop symptoms of the brain itself, of the white matter, and they develop what's so-called leukodystrophy, which is a chronic dysmyelination or a chronic abnormal myelination of the central nervous system, due to the fact that these are both enzymes that are defective in breaking certain substances down in the brain, and as a result, an MRI of the brain can be helpful in this situation because it can diagnose this leukodystrophy. The treatment of CIDP, again, a recurrent theme here. It's thought to have a humoral immune pathogenesis, meaning that it's thought to be antibody-mediated, and therefore there's a number of antibodies against substances that occur in the brain that have been detected in those patients. But importantly, both corticosteroids, IVIG, and plasma exchange, which have been used in various different studies, actually have a fairly good response rate. And oftentimes what will happen is that the patients will get treated in their acute episodes with steroids, and then they'll get follow-up IVIG as maintenance. The prognosis for CIDP, and this is our last slide, tends to be very good. The monophasic illness group tends to have a full recovery without any relapses. The relapsing group, as I mentioned, can have up to 5 relapses. The duration of the illness is about 7 years over which the relapses occur. The short-term studies of the kids off of therapy between 1 and 5 years suggest that the children long-term don't have little or no motor disability. However, the true long-term prognosis has not been studied, but it's thought to be excellent by most of the older pediatric neuromuscular folks. So, all right. So that's how we define these particular diseases when we're going through it in our mind in terms of trying to distinguish them. Does anybody have any questions?